Good evening, everyone, and welcome to our new season. We are on season 6, episode 1 of DocToks with Dr. Forrest Tennant and friends. We're glad to have a new season. We're glad to be with you all tonight, and we've got some really important things to share with you. Dr. Tennant has written a beautiful report with Dr. Guess and Dr. Purcelli, and I'll let him tell you all about that. Thanks so much, Doc. Take it away.
Yeah, thank you, Jamie. Tonight's show is Dr. Guest and I have a show planned that's practical. The idea is to have everybody who sees this to walk away with one or two ideas on how they can get better pain relief. Now, just recently, I and my associates, meaning Dr. Guest and Dr. Purcelli, we've written some reports, and we've just written a report that's going to be the basis of this program. And I believe the exact report is called How to Get a Better Effect Out of Your Opioids, okay, or something right to that effect. We've written some reports later, and they are on our website. So you could also look on the Arachnoiditis Hope website and actually get the reports that we're going to be talking about here tonight. But the basis of this program is how to get more oomph, if you will, out of the opioids that you are currently receiving. Now, why would we pick this subject? We're picking this subject for a very practical reason. The number one complaint I receive at the foundation is that people are getting some opioids, but they don't get enough. Okay? In other words, they're taking some opioids, but they don't feel it's enough or strong enough. But we've got to be very practical about something. The doctors of America are really put upon to prescribe opioids. Now, some of you know we are trying to work with medical boards, trying to work with advocacy. We'd like to have it to where doctors feel free to prescribe whatever dosage or opioid formulation is going to work. However, we're going to have to be very practical. Everybody blames the government, and indeed, when the government passed the 2016 Communicable Disease Control Center regulations, that became almost a law and pretty well said that doctors who prescribe over about 80 or 90 milligrams of morphine may even be criminals, and it's very inappropriate. Now, that turned out to be a disaster because that number was taken by the insurance companies, the hospitals, medical groups, third-party payers, and above all, malpractice carriers. And now what they've done with doctors is that they've made it to where even if the medical boards and the government comes in and changes this figure is in everybody's backyard now. And so to find a doctor who will go above that is very unusual. And you'll have to have a good documented case to have a doctor go above that. And so what we really have is a practical situation in that you're going to have doctors who are going to be willing to prescribe you, let's say, 4 to 6 Vicodin a day, maybe Percocets, maybe oxycodone 30s, 2 or 3 a day. Maybe you can get some low-dose methadone, 40 to 80 milligrams a day. In other words, you'll be able to get a certain amount of opioid drugs, but you're not going to be able to maybe get what you need to really control your pain. In other words, you'll get partial control. And so what we're going to do here tonight is dealing with this whole issue of partial opioid treatment, okay? And I don't know of a better name than that. It's partial, okay? And so also thrown into this basket is buprenorphine or Suboxone. We have a certain group of physicians and medical groups in this country now who worship Suboxone and buprenorphine. They think that should be the treatment for everybody because you also have this same group who managed to convince a big part of the medical profession that anybody who's a pain patient also has opioid use disorder, meaning you're going to abuse your opioids. Okay, and we know that's not true. We know they're safe, but nevertheless, they believe this, and changing that perception is going to be a long time in coming. So tonight, what we're going to do is kind of be practical and see if we can't come up with some tips for everybody, regardless of where you're at with your opioid dose, to make your opioids work longer and stronger. So that's the purpose here tonight. And we've got I think, some very fascinating information for you. First thing we want to do, there's an old term in pharmacology called potentiation. Now, Dr. Guess, are you here with me here now?
Yes, I finally got everything to work.
Hey, there you go. Boy, you're looking good tonight with that hat. I'm telling
Thank
you.
you.
Yeah, you can keep the sun out of your eyes.
Indeed.
Now, if you could just keep the bureaucrats
And off my head.
there you go. All right. Now, as a pharmacologist, I thought you'd be a good one to explain what does the treatment, the term potentiator mean in simple terms. It's an old one, but everybody to start working about how we get better effective opioids, this is a place to start. What do we mean by that term potentiator? And then how can people take advantage of it?
For a potentiator, we're trying to get a couple of things to happen. The easy one is we're trying to get more effect out of what we have by adding something to it that's either going to complement it, say like aspirin, sometimes even Tylenol, or something that's going to stimulate the receptors to potentiate to get a bigger effect out of it when we add an antihistamine, like, hospitals forever, Phenergan and Demerol. That was the standard for any pain because Demerol was very strong. Phenergan gave it an extra little push on top of helping with the nausea that's often associated with a big dose of an opioid. So anything that's going to make it work better. And there's a couple of different mechanisms we can do it with. I probably won't go too deep into it, but just to give it an extra push.
Yeah, in other words, maybe that's the whole concept, of course, of something called Percocet or Vicodin, in which they
Absolutely.
combined these two things. Uh-huh. Now, uh, what can you recommend to people listening that are taking their opioids? Do you have a laundry list of potentiators or boosters that they could take with their opioid?
Uh, yes, there are a number of them. Of course, aspirin has been around forever. Uh, since since the Europeans came to America and started talking with the natives, they used a product called white willow bark tea. And as we know now, that's kind of the basic organic precursor to aspirin. If you're going to use willow bark tea, do not use aspirin together because you get too much out of it. We've got taurine. We've got, of course, the antihistamines like now Benadryl is most commonly available to people because it's over the counter. I don't think the non-drowsy antihistamines like Claritin are going to do much for it. You need the stronger ones. Benadryl is the gold standard. If you have Phenergan available to you, you could use that, but that's prescription, and that's going to be harder to get to. I've got St. John's wort listed here as a potentiator. It's most commonly used as a antidepressant because it has similar properties to Zoloft, but it can give you a little bit of boost on your opioids as well. Dr. Tennant was talking about PEA a couple of weeks ago. Is going to give you a kick, and that's kind of more of a complementary than a booster. So you're getting, like aspirin, you're hitting a whole different set of receptors to get some increase over it. And that's kind of my list that I've got.
Of course, today you've got one of the big things is CBD and marijuana. Where do
Oh,
they?
yes. Potentiators, I'm not sure about. They kind of work by a whole different. Well, yeah, it's gonna give you more benefit. So yes, and it works by a whole different mechanism of action because we have cannabinoid receptors in our brain, and it does its job as well.
When you take one of these, let's say you're going to take Benadryl, should you take it right with your opioid at the same time in the same swallow? Take it just before or right afterward? Do you have any recommendations on that?
You can take it at the same time just because that's probably when you're going to remember to do it. but you're going to get a better effect from it if you give it about 20. Anything you take orally takes about 20 minutes to dissolve and another 10 or 15 to absorb into the system and start working. So anywhere from 15 minutes to a half an hour before your opioid, then that Benadryl is in the system. It's starting to do its job. And then when the opioid gets there, it's got that extra help already in place instead of kind of running together.
Okay, so that's your list there. Okay.
Yeah.
The next thing I'd like to cover is bedtime medications. Okay. Now, we've noticed for years that if a person takes certain compounds at bedtime, they get better pain relief the next day. Scott, what can you tell us about that mechanism and what all?
Oh, well, tryptophan was very popular for a while. Um, they say that's why you get sleepy after a big turkey dinner. And then it went off the market for a very long time because they found some impurities in it because it was all being made in, I want to say Japan, and there was some kind of impurity in there that was causing a problem, arthritis. So they took it off the market. It has now come back in a more pure form, which is now safe to take. And I like tryptophan. It works great. Uh, Personally, what I take is not is melatonin, but not melatonin by itself. I tried it by itself. Didn't do me anything. I like to combine melatonin with L-theanine. And anywhere from 3 to 10 milligrams of that melatonin with about 200 milligrams of theanine just does marvels. I started dreaming again. Um, what it does for me and what I've spoken with a lot of people that theanine does is it turns off those voices in your head while you're trying to sleep. And that can be so important because, you go to bed and you start arguing with the DEA, you start arguing with the state board, you start arguing with your doctor in your head, and you just don't fall asleep. That theanine and that melatonin just does an awesome job. Uh, any of the tricyclic antidepressants do great for sleep. Amitriptyline, again, is the gold standard. Um, it can take, most of these you want to take about a half hour. Well, the melatonin you want to take with dinner. Most everything else you're going to take about a half hour before bedtime because, again, that 30 minutes for it to get in there and start dissolving and get to working is what you want. The antidepressants, tricyclics like amitriptyline, they have a tendency to be very drying. If a person can't take it, it's going to be that drying problem that does it for them. And then there's a bunch of others. Trazodone, the old Deseril, works great for sleep. Um, there's a antipsychotic called mirtazapine, and that works fairly well for sleep when others don't. And it's a very specific dose, 7.5 milligrams of mirtazapine. If that works, great. If it doesn't, taking more is not going to help at all. So you don't need to, you give it a try for a couple, 3 or 4 days. If it works, great. If it doesn't, move on to the next one because it's just not going to. We have metformin here. I don't usually use that as a sleep booster, but boy, does that really help with the inflammation in the spinal cord. And anytime we can turn that off is a good thing. And it seems, I know Dr. Porcelli has experimented with patients taking it in the morning and in the evening. And as it turns out, he's getting his best results for those who take it in the evening.
Yes.
That's what.
I'll chime in on the metformin for a moment.
Okay.
I'm a great believer, and in fact, I like to start off with the first dose being in the evening at bedtime, and then maybe add one later in the next day. But metformin is turning out to be a great booster for anyone who's on opioids or who needs pain relief. Would you like to make any comments on why we think it works?
Well, that's kind of, I alluded to it earlier. It gets into that spinal column and it stimulates the production of anti-inflammatory cytokines. And that's we're digging deep into the bushes on that one, but that's how it works. And your doctors are always going to accuse you of being diabetic, and so is your insurance company, but because they just can't get around this newest information that says we can use this for improving those anti-inflammatory cytokines in our spinal column.
Yeah. So metformin is a winner.
Oh yes.
No question about it. And of course, you like melatonin with threonine. old-fashioned
Yes.
tryptophan, still good at bedtime.
Yep.
I think the theory on, for example, tryptophan, is if you take it at bedtime, it adjusts your serotonin receptors and they stay good and adjusted the next day. So therefore, you're going to get better pain relief the following day, not just a better night's sleep, but better pain relief the next day. That's how we believe it works. Okay. So give it, you can't hurt yourself with these things. So give it a go. Scott, the next thing I want to talk about is the route of what we call the route of administration. Okay. In
Yep.
other words, basically, we swallow most drugs, we inject a lot of them, but we've also got suppositories and we take drugs under the tongue and what have you. Can you give us a little lecture on where on alternate ways to take opioids other than just swallowing it?
A lot of medications, when you take them orally, the first place they go is the stomach. They dissolve, they get taken up by the blood, and the next place they go is the liver. And the liver is one of our primary detoxification organs. And for a lot of medications, about 50% of your dose is going to get killed in the liver before it makes it to the bloodstream. So there's different routes to get around that. One is the injectable because it's going straight into the muscle, and you bypass that what we call first pass effect of the liver. You can also do the same thing with a suppository. In Europe, suppositories are common, they're well accepted and used quite often. They're really not accepted in the United States. For some reason, we have not embraced them as a dosage form. So it's hard to find that dosage form in the US, and it's also hard to find people who are comfortable using that. And the dose is the same, whether it's oral or by a rectal suppository, because the absorption is the same. But again, the blood doesn't go straight to the liver, so you don't kill half of your dose. The other and most common way to speed up absorption and to bypass that first pass effect in the United States here is to do a sublingual dosage form. Now, ondansetron or Zofran used for nausea, there's an oral form and a sublingual form. Now, both of those have the same dose, but it's more for onset of action. You just put that under your tongue and that little raspberry thing dissolves and wow, you're feeling better in 15 minutes as opposed to 45 minutes. A lot of our migraine medications are sublingual. None of our opioids are available in a sublingual dosage form.
Oh, do you have any other thoughts that you would like to bring up? Any other tips that you can come up with to boost their opioids?
Well, we talked about cannabis. I have kratom listed down here,
Yes, tell
and
us about
it's
kratom. Yes.
well, it's one of those drugs which is still having a lot of controversy. There is a very powerful community of patients who use kratom with great success. And they have also a very strong lobbying group because kratom has not been controlled or attacked by the DEA ever. Just recently, the state of Illinois is trying to make it a Schedule I drug where it's completely banned. And there have been some adverse events and bad outcomes with kratom. I think what you really have to do with that medication is make sure you have a good source of kratom. Some of the stuff that's out there is not made well. It's being washed and rinsed with kerosene or gasoline and has lots of contaminants in it. So kratom has shown to be very useful in patients with pain. But my my warning on kratom is to make sure you're getting a really solid source that has good production techniques and is nice and pure.
That's great. Thank you very much, Scott.
You're welcome, sir.
Great tips. What I want to do here in the remainder of the program is talk about two aspects of pain relief that we've touched upon before, but I'm going to touch upon them again here tonight. One is what is known as central pain. Okay. Now, what I want everybody to grasp on this is this. There you have regular pain, which is kind of intermittent, ebbs and flows, comes and goes. And then you have constant pain, pain that never goes away, 24/7. Now, people who have that 24/7 pain need to understand what has happened to their central nervous system. And what has happened is this, is that the glial cells inside your brain and spinal cord have become attacked either by excess electricity, autoimmunity, but they have gotten together and they have become dysfunctional. It is the glial cells, and they have a couple of subtypes called astrocytes or microglia. You don't need to know that, but what you do need to know is that in severe chronic pain, there is a certain number of people who develop constant pain, 24/7, never goes away. And the mechanism for that is when the glial cells are become dysfunctional inside the central nervous system. Their normal function is to take pain signals, and pain is a form of bioelectricity, and to shut it down. But they have become diseased and they can't shut it down. So constantly, your pain never goes away. It is always there. And you're going to have to treat this in a special way. Now, if you have constant pain, you're going to have understand that that constant pain really has three components. You have what's called ascending pain. That's the pain that's going to go from your arachnoid to your brain, from your damaged leg nerves to the brain, from a joint maybe in your elbow to the brain. That's the ascending pain, the pain that starts out in the body somewhere and goes upward, ascends up the spinal cord into the brain. That's known as ascending pain. That is the normal pain of the human body. Now, when you develop this constant pain, you develop two other kinds of pain. One is called descending pain, and the other is called, the doctors like to call it neuropathic pain. Okay. Now let's take neuropathic for just a moment. Neuropathic is kind of a big long term, and all it really means is damage to nerves. Okay. And that damage to nerves means that the bioelectricity cannot pass, and therefore it's become customary today, and practically the doctors of America are doing this. They do like to treat neuropathic pain. Unfortunately, sometimes they think that's all they have to do, and they prescribe you a neuropathic pain agent. Probably the most common one today is gabapentin. Baclofin's right up there. A lot of us like the old-fashioned benzodiazepines like Xanax or Valium or Ativan. Carisoprodol is an old one that is great, but a lot of doctors don't like to use it anymore. And tizanidine, clonidine, I'll get to those in just a second. Those are part of descending pain, I'm sorry. But neuropathic pain, your doctors are going to want to give you a baclofen, a gabapentin, maybe a benzodiazepine, because if you have constant pain, you're going to need a neuropathic agent as well as your opioid. So opioids are for ascending pain. Your benzodiazepines and your other agents are for neuropathic pain. But the one I want to focus on, and which I've done before, but I want to repeat it, you've got to have to treat your descending pain. Here is what happens when those glial cells cannot shut your pain down, and that is bioelectricity accumulates in the central nervous system, and the brain starts sending it downward through the vagus nerve and through some of your ganglia along the spinal cord. In other words, the pain signals aren't going upward, they're coming downward. And opioids don't take care of that pain very well. What does take care of it are drugs that stimulate a different receptor. That receptor is known as the noradrenergic receptor or the dopamine receptor. And I want to mention what some of those drugs are. My favorite drug to treat descending pain is methylphenidate. That's Ritalin. I also like Adderall. I like dextroamphetamine. I like the pure dopamine drugs. A lot of doctors don't like to prescribe those, but the one they will prescribe is modafinil, That's Provigil, and that's a nice, safe drug. As far as your non-prescription drugs that work pretty good, St. John's wort's in that category, and lion's mane is in that category. Other drugs that doctors will prescribe that work fairly well is clonidine and a drug called tizanidine. That's a muscle relaxant, but it also works on descending pain. So in other words, if you have constant pain, in order to get good pain relief, you're going to need an opioid, you're going to need a neuropathic agent, and you're going to have something to do with descending pain. Scott, you want to chime in on this and make any comments on this?
Well, I think you covered it fairly well, but descending pain. When I first started studying pain management, that was the hardest concept for me to figure out as to what this descending pain was, and I finally got a handle on it. But yeah, if you can turn off the sensation going up the brain that says it hurts, but if the brain, the few signals that get through, if you're not turning off the descending signal that says, yeah, it really does hurt, and you're not getting anywhere. So you got to turn off both the hot and cold water to not fill up and overflow the tub.
Yeah, and for those of you out there listening, you may have to get some written materials. You may have to educate yourself and take this information to your pain clinic or to your doctor, because I'm going to wager that you couldn't find more than a handful of pain clinics in this country who even understand the components of central pain. And so you're going to have to do a little education of them, and they need it, I must say, okay? And for you to get good pain relief, you're just going to have to, and if you've got constant pain, you've just got to deal with the three components of constant pain. Now I'm going to shift gears for just a moment.
Dr. T, can I jump in for just a second?
You sure can.
Sure. On that centralized pain thing, what really helped me understand it the best is the ascending pathway is telling you that it hurts. And the descending pathway is what they also sometimes call it the inhibitory pathway, which is your brain trying to tell the body, no, it really doesn't. So unless you get them both going, you got to get them both going. And right now, for years, we're only been treating that ascending pathway. And when I was in school, we were told forever, never prescribe an opioid or a downer with a stimulant like methylphenidate or Ritalin. It's the slippery slope to addiction. And there was a hospital in England, Brompton's Hospital, and they made a cocktail that was one of the best pain medications we ever had, and it was cocaine, opium, and what was the third component, Dr. Tennant? I can't remember.
The third component was, believe it or not, a neuropathic agent called alcohol.
Alcohol, that's right. So, yeah, we've known this forever. We just don't want to accept it.
That's exactly.
I'll let you go back.
Yeah, you bet. Now, to close this out tonight, I want to talk about the age-old thing that I hope that you accuse us of harping on this, and that is to really get pain relief, you've got to treat the underlying cause, okay? And we now know that certainly with arachnoiditis, both adhesive and non-adhesive, certainly with CRPS, certainly with severe osteoarthritis, most people with multi-system diseases, that inflammation is there lurking. And next week, perhaps I'm going to talk about, we just finished a cytokine study, which is very important, that deals with this. But to get pain relief, you've got to cut that inflammation down. Now, I want to leave you with two things here tonight, of which one may be, I don't know, it could be a game changer. And I'm going to cover what that is. Earlier, Scott mentioned PEA, that's palmitoy ethanolamide. Now, this is in the body secretes PEA when you have pain. And we do know that it works on the serotonin receptors and on the cannabinoid receptors as a pain reliever, but it acts like a hormone. It's also an anti-inflammatory agent. And we do have people today who are using it in a variety of ways. It usually comes in a 300 or 600 milligram capsule. Some people like to use it as a potentiator or a booster, take it right with their opioid and get a better pain effect. That's worth trying. We also now have people who take it about twice a day, and I would highly recommend to people to get PEA at 300 or 600 milligrams, take it twice a day for 10 days, and see if you get a good reduction in your pain. It's nice and safe, and it's worthwhile, and we're getting reports that it really does work in some people. If it does work, then you can go ahead and set up a schedule after the 10 days where you take it 2 or 3 days a week. So PEA is well worth trying to see if you can't get a permanent reduction in your pain. Now, the last one I want to talk about is the new kid on the block. And I don't want to overstate it, and I don't want to sound too missionary about this, but ivermectin is fast becoming a mainstay for a lot of people. Now, what is ivermectin? Ivermectin is an anti-parasitic drug, and it works on a lot of things we call parasites, not just intestinal worms, but also viruses like Epstein-Barr are parasitic, and it does work on these viruses. But it's also a very potent anti-inflammatory drug. It looks like it's almost got the same anti-inflammatory capability as does Toradol. And so people, it's the fastest growing drug among the adhesive arachnoiditis community. And if you want to try to take ivermectin, here's my recommendation. It comes in 3, 6, and 12 milligram capsules. It doesn't make a lot of difference what dosage. Pick one of the dosages, take it, let's say you take a 3 milligram, take it twice a day for 10 days. If you find your pain is reduced, then set up a schedule to take it 2 or 3 days a week. But I did want to bring to your attention that ivermectin has become, I don't want to say it's quite in the mainstream at this time, but it's from what I can tell early on, it's got the anti-inflammatory potency and pain relieving potency of ketorolac. And people are starting to use it right and left. And it also originally we started using it was to kill off the colonies of Epstein-Barr virus. So we may be getting two effects out of this. We may be knocking out the Epstein-Barr virus colonies that are in the body, as well as getting an anti-inflammatory effect. So for all I know, I may come back to you within a short period of time and tell you that this should be the step one in the new protocols. It really, at this point, is the first thing that's come along that really seems to be a consistent pain reliever right along with methylprednisolone and ketorolac. It may be our third really big gun as the way it looks at this time. Can't promise anything, but the one thing that I do want to call your attention to, the studies are out, and it's pretty clear that it may even be the Epstein-Barr virus or the autoimmunity of the Epstein-Barr virus that causes central pain. And so the use of these things are extremely important and may give us a way to get an awful lot of pain relief and get us into, maybe we can't cure these diseases, but we can sure get a lot of cure in the sense that we can reduce a lot of symptoms permanently. At this time, I just want people to know PEA and ivermectin are worth trying. And we'll talk more about it on the show. Plus, it's on our website and in our bulletins, and we'll try to keep people informed. But I did want to bring you the very latest. Again, Jamie, thank you for bringing us on here tonight. Scott, thank you so much for these words of wisdom.
You're very welcome.
I do hope everybody who watches this tonight learns something and improves their pain care. With that, we'll sign off until next week. Good night.
Thank you, Dr. Tennant. Thank you so very much. And thank you, Dr. Guess.
Thank
What
you,
a
Doctor.
great informative show. I don't know about you all, but wow.
It was
That
great.
was amazing.
Yes, indeed.
Very good job.
Thank
Very good. I don't know if everyone saw in the chat that we did include the PDF that they wrote. It's the report of how to get more relief from, or how to get more pain relief. That is on arachnoiditihope.com under the tab at the top that says reports. So I hope that's helpful to you all. This has been a great help for me. And again, ivermectin has helped me a lot. I love you all. I hope you have a good night. Thank you so much for joining us, and we'll see you next week.
Thank you again.
Thank you
bless
too. God
everybody.
bless you all.
God bless you
God
all.
bless.
Thank you so much
Good
for
night. Thank
everything.
y'all.
Good night.
y'all.
Bless everyone, y'all.
Love you,
Are we
Brando.
gonna do 30 minutes from now on?
We do, depending on what Doc has prepared, we might have half-hour shows 3 days per month, and then the full hour is usually with advocacy. It just depends. You never
Okay.
know how life
Yeah.
goes. I know you know how it rolls, Carson.
Yeah.
Well,
Yeah.
I'll tell you before I see you again. Happy birthday, Carson.
Happy birthday, Carson.
Yeah.
Happy
Carson.
birthday to you too, Carson.
Yeah. We got to tell Karen too.
Yes, our birthday triplet. We'll have
Yep.
to let Karen know that we wish her happy birthday as well.
Well,
So
you
I'll be
do
a year
have
older when I
happy
see you all
birthday.
next, and just we hope I don't act a year older or seem a year older.
I'm older. I'm definitely older.
No, you're precious. You guys are all precious. Thanks for being with us
You are
tonight.
too.
Love you guys.
Thank you, Jamie.
Thank you.
God
I
bless
love you all.
Love
Good night.
you. Bye.
Love you too.
Love you too.
Love you, Pam.
Love you too.
Hmm.
And Jackie, by the way, by the way,
What?
Donna Wilkes, Jacqueline Griselle, and Brandon Pollard are the winners of our DocToks drawing. Brandon has said that he wants to give his gift to someone else. He's just like that. Brandon would rather give than receive. And so
Yeah, let someone else have it.
you're precious, Brandon. Thank you for that. So what I've decided to do is take everyone's name that's in here tonight, and I'll just do the old-fashioned, the little shake it up thing, but I have a random number drawing thing that you can do online. I'll put a number beside everyone's name, and then we'll do a drawing, and one of you will be a winner. It's not a big, huge prize, not a big deal, just a little something to let you know you're appreciated. Thanks so
Good.
much. You all have a good night, and God bless you.
You too.
Thank
I
you.
love y'all
Jamie.
Y'all stay safe.
too.
God be
Thank you
with
so
you.
much.
Uh,
Good night.